Chapter 4 goes over pain. So your book defines pain as the unpleasant or uncomfortable feeling or sensation that comes from the stimulation of pain receptors. Pain is a defense mechanism that your body has as a warning sign to help prevent any further damage. It's your body's way of saying like, oh, it hurts when I do that. I shouldn't do that anymore. Pain is a complex concept. We don't really understand it very well. It's difficult to measure because someone else's pain might be different than your own pain, just based on how you respond to it. So something that I might rate at a pain level of 10 out of 10, you might rate at a pain level of a 3 out of 10. So we say that pain is subjective. So remember when we talked about subjective versus objective. Subjective is what the patient says. So if the patient tells you that they're having 10 out of 10 pain, we treat them for 10 out of 10 pain, regardless of what our own opinion is or what we, think they might be feeling. We take it as their word. So pain can be felt for different reasons. It can be felt because of inflammation or swelling or ischemia. Remember that lack of blood flow to an organ or other part of the body. It can be felt because of infection or tissue necrosis. Remember that tissue necrosis is tissue death. Don't forget that necrosis versus ischemia. Ischemia is a lack of blood flow and necrosis is death. So necrosis can be caused by ischemia, but they are not the same. So we talked about that, but I want you guys to make sure that you're able to differentiate between those two. Pain can also be felt because of chemicals or burns. So all of these potential problems stimulate pain receptors, which are called nociceptors. These are the nerve endings in most of the body's tissues. So again, just let me repeat that. All of those problems that I just listed stimulate the pain receptors or nociceptors. These are those nerve endings that we have in most of the body's tissues. The intensity and duration of the pain depends on whatever caused the pain. Was it acute or prolonged or both? It also depends on if you have tissue necrosis. So if you have tissue necrosis, that's going to be painful at first, but once the tissue is actually dead, it no longer has feelings. So burn can be extremely painful depending on the degree of the burn, and then that recovery is long and painful as well. Again, remember in necrosis, we have that tissue death. So nerve endings die, they no longer hurt, but the area around that dead tissue is going to be incredibly painful. So again, if the burn is severe or if the, whatever issue that's causing the pain is severe, those nerve endings can be damaged. And the worst part, that necrotic part or that part that has necrosis is not going to hurt, but that tissue that surrounds that dead area will be very, very painful. So we have two types of pain. We have somatic pain and visceral pain. Somatic pain comes from the skin, bone, or muscle. It's relayed by sensory nerves, and then our visceral pain comes from the organs, and it travels by sympathetic nerve fibers. The pain pathway is on page 54 of the old book. I'm not sure what page number it is on in the new book. So you should have a basic understanding of that pain pathway and how pain, is relayed to the brain, and then what we do, what our body does about it. So nociceptors, those pain receptors in the skin or in the body are stimulated by thermal means, which would be like extreme heat or extreme cold. They could also be stimulated by mechanical means like pressure, or chemical means like acids or different compounds that are produced in the body. So then we have, so that's our stimulus. Our nociceptors are stimulated by the stimulus. Then we have afferent nerve fibers that travel or that carry that sensation to the spinal cord and brain. And then our brain decides what we're going to do about it. Then the efferent impulse travels down to the muscles and give us the response. Usually it's involuntary. This all happens very quickly and we don't even notice it. So again, after those nociceptors are stimulated, the afferent nerve fibers transmit the pain signal to the spinal cord and brain. Then that reflex response is triggered that causes an efferent impulse into the muscles that creates an involuntary contraction to move away from the source of pain. So if you touch a hot stove, the nociceptors in your hand are stimulated. The afferent nerve fibers send that pain signal to the spinal cord and brain. Then an efferent impulse creates the reflex of pulling your hand away. So again, it happens very quickly. You don't even notice that it's happening. It's just that quick, but this is like kind of a lengthy process of how it happens. It's important to know those different pieces. Then we have a couple other terms I want to talk about. The pain threshold. This is a phrase you might see along with the pain pathway. The pain threshold is the level of stimulation that needs to happen in order for the activation of the nociceptors to feel pain. This is pretty similar in everybody. We all react to it differently, but we all basically have the same pain threshold, okay? Then pain tolerance. This is what changes from person to person. This is the ability to handle pain or to perceive the pain intensity. So I mentioned we all feel pain differently. I might step on a nail and it punctures my foot and I would be screaming. While my diabetic stepdad, he can barely feel his feet. He might step on the same nail in the same area of his foot and it might just be, uncomfortable for him. So this is that pain tolerance, not the pain threshold. Make sure you can differentiate between the two, tolerance and threshold. Then we have the gate control theory. This is an explanation of the pain pathways. You should know this as well. So our control systems, or gates, are built into the normal pain pathways that can change the entry of pain based on different factors, like environmental factors, health factors, the sympathetic response, distraction, etc. So these gates can open where the nerve connects to the spinal cord. That's called the synapse. They allow the pain impulse to pass from the nerves into the spinal cord and brain, or they can close and reduce or modify or stop the impulses from traveling. So this is important. We do lots of things to close that gate. So that way, the painful thing is still happening, but the way that we interpret it is different. So that gate can be closed by things like putting ice on a painful site, applying a TENS unit, which is like a nerve stimulating unit, distraction by other things that are going on, opioids, both natural and synthetic. Synthetic opioids are the narcotic pain medications that we use for pain control, and natural opioids are endorphins. Those are like your feel-good hormones. Serotonin is a neurotransmitter that can increase the release of those endorphins. So these are different things that can close that gate so that we don't interpret the pain the same way. So when you're taking, like, for example, a narcotic pain pill or pain medication, it's not taking the pain away. The painful thing is still happening. It's just changing the way we perceive that pain. So then when we're talking about signs and symptoms of any disease process or abnormality that we go over, we're going to talk about the objective signs, which again, that's what you see, it's what you observe, it's what you measure. And then our subjective symptoms, which is what the patient tells you they feel. Any of our subjective symptoms we can't see. We might be able to see that you're uncomfortable, that you look like you might be uncomfortable or whatever, but we don't know exactly what that is. So we just take what the patient tells us. So what are some signs of pain? And then what are some symptoms of pain? So some signs of pain would be pallor, okay? Are they pale in their skin? Tachycardia, hypertension, their facial expressions. Are they grimacing? Okay. Are they sweating? Are they vomiting? Do they have tense muscles? Are they guarding or covering the area of pain? Are they restless? So these are some signs of pain. Some symptoms of pain would be like the patient telling you there's a sharp pain there, or a dull, intense, aching, throbbing type of pain. Is it generalized? That means like all over the body. Or is it localized to a specific area, like chest pain or pain at the site of an injury? Any radiation pain or radiating pain, that means like it starts in the chest and it moves over to the arm or shoulder. Does it increase with movement or activities like eating? So again, signs versus symptoms. And when we talk about pain, we use that scale of 1 to 10. 1 is you can hardly feel it, and 10 is the worst pain of your life. So again, this is subjective. You might have a patient that's saying their pain is a 10 out of 10. They look totally relaxed. Maybe you have someone that's diaphoretic and short of breath with tachycardia, and they're doubled over, and they say that their pain is a 4 out of 10. Now, if I have the patient that says they're a 4 out of 10, I might discuss their pain a little bit more in depth to see if they really do have that higher pain level. Some people don't want to take pain medications for one reason or another, so it's important to address that. If someone rolls in on a stretcher and their whole leg is smashed and mangled, but they don't want pain medication because they're afraid of addiction, I want to talk them into letting me give them pain medication. Pain can cause all sorts of other problems throughout the body that we don't need, so it's important to get it under control. So what do we do when we have a kiddo that doesn't understand that 1 to 10 pain scale? If they're old enough, we have a FACES pain scale. They can point to the face that looks the way they feel. And if they're too young for that, we assess what we observe to determine their level of pain. We look for things like tachycardia, hypertension, facial expressions, things like that. And what if someone can't communicate with us? Again, we observe them to determine their level of pain, to kind of assess a number that we think is appropriate for their level of pain. So some other characteristics of pain or terms I want you to be familiar with. Referred pain. This is pain that's felt somewhere other than the source of the pain. A common example of this is jaw or shoulder pain during a heart attack. We hear this a lot. Then we have what we call phantom pain. This is pain or itching in a limb that was amputated. So after time, the nerve pathways do reroute, but this can take a long time, and sometimes it never goes away. And then we already talked about that pain tolerance. So we have acute pain. This is sudden, severe. It's short term. It indicates tissue damage, but it can get better once the cause has been treated. It can be localized to one area or generalized throughout the body. It creates a stress response like hypertension, tachycardia, cool, pale skin, tachypnea, muscle tension, etc. Possibly even vomiting. High anxiety and emotion can come along with this acute pain as well. And then our chronic pain. Chronic pain is long-term. It can create long-term problems too, like being unable to work, depression, social withdrawal, lots of other issues associated with long-term pain. This is much harder to treat than acute pain. The book says that it typically is generalized, but it can be localized, like chronic low back pain. We see that a lot. The body cannot maintain the stress state, which is your hypertension, tachycardia, and tachypnea, for a long period of time. So the person is usually really tired, they're irritable, they're distressed. The pain might cause trouble sleeping. It might cause a loss of appetite. Chronic pain reduces tolerance to other injuries and illnesses as well. So in the old book, there's a table on page 60 that compares acute and chronic pain. I would be familiar with them and make sure that you're able to differentiate between the two. So some other types of pain, we have central pain. This is caused by damage to the brain or spinal cord. Then we have neuropathic pain. This is caused by damage or disease to the peripheral nerves. Ischemic pain, this is again that loss of blood flow. So ischemic pain is a sudden loss of that blood flow to an organ or tissue. Then we have cancer-related pain. This is usually chronic and can be caused by the advancing of the disease or the treatment of the disease or other coexisting diseases. It's very debilitating. It's intense. There are acute phases, but again, it's usually chronic. So the first thing we want to do with pain is remove the cause of the pain, right? If you fall into a cactus, you want to remove all of the needles before you do anything else. Oral pain medication like acetaminophen, which is your Tylenol, or ibuprofen, which is your Advil, work really well with mild pain. And ibuprofen works great to reduce swelling. So swelling can be a big part of pain. Opioids like codeine and oxycodone are stronger, and they can be combined with acetaminophen for stronger prolonged pain relief. But that ibuprofen is huge for swelling. We see ibuprofen given a lot, especially for like orthopedic procedures, because Lots of times we're giving, the heavy duty narcotics and they're really not cutting it as far as pain control goes. And then we give ibuprofen and we're removing that source, which would be the swelling, and they experience a greater level of pain relief there. So for severe pain, we give even stronger medications like morphine or Dilaudid or fentanyl to help control their pain. We can also give sedatives to relax our patient, and I'm not talking about like completely sedating them. I'm talking about relieving their anxiety so that they can rest and relax. We can use non-pharmacologic pain relief techniques like ice, heat, repositioning, yoga, and massage if it's appropriate for the type of pain we're dealing with. And then finally, we have anesthesia. So local anesthesia is an injection that blocks the transmission of the pain, like lidocaine at the dentist. Then spinal or regional anesthesia is giving local anesthetic as a spinal block or nerve block that blocks all the pain receptors below the site of injection. And then general anesthesia, this is gas or injections that induce the loss of consciousness in our patient, which in turn helps with pain.